Good afternoon, everyone. It's a pleasure to be here today at Endocrine Grand Rounds here on March 19th. It's my honor to introduce Dr. Courtney Pierron. Dr. Pierron graduated, got her medical degree from Ohio University, Heritage College in 2020. She then went to pediatric residency at Wright State University at Dayton Children's before joining us in 2023 for our Pediatric Endocrinology Fellowship Program here at Norton Children's and the University of Louisville. In addition to her endocrine and diabetes experiences, she has some international experiences, and she's going to speak to some of those interests in global health today. And she also happens to be our resident tennis pro. So if anyone wants any tips, you know who to ask. So again, thank you and welcome, Dr. Pierron.
All right. Well, thank you for that introduction. So as you can see, my presentation today is about endocrinology and global health. Our objectives today are going to be, we're going to just kind of think about what are the most common endocrinopathies that happen here in the US, but also worldwide, and kind of how do we compare with each other. And then understand the differences in clinical practice, maybe in settings where we have in the US and also settings where we have in Europe, but also some settings where we don't really have as many resources as we're used to. And then our third objective will be discussing what opportunities may be available for us to do more work in the endocrine world and in the diabetes world, both domestically and internationally. With every presentation, we also have to start out with disclosures. So I have no potential conflicts with anything I present today that I am aware of. I won't be discussing any off-label use of medications today. I will be discussing costs of medications, but I have no buy-in into any of that. Okay. Now, I know Dr. Winegers introduced me, but every global health lecture, every global health experience I've ever been in, the best way they start out is if you explain kind of your perspective on the world and where you're from and your background to know kind of where you're coming at with everything that you're into. So I am from that little red dot in Ohio there. It is called a small town called Wheelersburg, Ohio. When I graduated high school and left Wheelersburg, Ohio, we had a population of roughly 7,000 people. It's beautiful there. It's mostly country. We're on the outskirts of the Appalachians, so lots of hills. I also grew up on the river, so as you can see, this is how we spent most of my childhood doing the things. And my family owned a greenhouse, so I grew up planting flowers and doing all the hard work in the field. But my background led me to do the things that Dr. Winegers was saying. So I went to college. I played tennis, which is a big part of kind of how I saw the world, because growing up, I went to all these tennis tournaments in lots of different places, got to experience lots of different things. And then in college, having that experience again, and then medical school, I wanted to find a way that I could figure out how can I continue to travel through my career, because I know that it has such a good impact on me as a person. So I found this program that was a child life in medicine in South Africa. It was through a company called Connect 123. In South Africa, if you're not familiar with their healthcare system, they have a government healthcare system. They also have private healthcare, as in most countries. What I participated in was I was at the Lotus River Day Hospital, which is called a primary hospital. This is where you would think of that you go for visits. So people would come in the mornings, they would spend all day, they would see their primary care doctor. Sometimes if there was a specialist around, they would see them there. If they had wounds, this is where they would have their wounds dressed. I always make the joke that I went to South Africa and became a fitness instructor because I actually ran the cardiac rehab exercise program in the mornings every morning. And kind of just a little general different things. They would come with their own chart every morning. They would spend most of the day there and then they would go home. Another part of my experience, so we would spend 1 week at Lotus River, and then the next week we would spend at Victoria Hospital, which is kind of your secondary hospital, which you would think of as this is like your community hospital, so where you would get admitted for inpatient. So they had one pediatric floor on the top floor. They had an OR, but they weren't doing any crazy difficult surgeries. They're doing appendectomies, the easy things that are there. As you can see, it is an old mansion that was converted into a hospital because that was how it was donated. So it's very beautiful and very beautiful on the inside. This is also where you would still have a TB ward. All those things still happen. And then I'm going to pronounce it wrong because it's been a long time since I've been in South Africa, but it's Groote this is the hospital that you think of as the tertiary hospital. This is actually the hospital with the busiest ER in the world because of the violence that they have and all of the stabbings and the shootings that happen. While we were there, we saw some crazy things, I will tell you that. This is also the hospital that's claimed to fame for the first successful heart transplant. So we got to be in the OR to see where all that happened. They have everything staged. It's actually really cool to be in. So kind of these three experiences. On the weekends, we chose to do clinical things because we're nerds. So we would hang out at the children's homes for the children who don't necessarily have families, but they're medically complex, or also the children who were HIV positive and they stayed there because their parents had died from HIV. So those were kind of the things that we did. We spent roughly 6 weeks there, had a blast, saw lots of things. So I will tell you that through the slide today, I like to travel, so I tried to include mostly my own photos. So everything today is somewhere I've been. I tried to provide a descriptor, but that's where we are. But so my motivation for doing this presentation is going to be because in May, I will be traveling with UofL to Ghana, to Tamale, Ghana, through a program called AMPATH that we have a relationship with. So that is the Tamale Teaching Hospital, and hopefully I have a great experience. There is a pediatric endocrinologist that is from Tamale that has retired and has moved there, and I will be working mostly with him while I am there. So I'm very excited. So why do we care about this? Why is this important? Why should we talk about it? We should talk about it because when we look at just the physician workforce in the world, we look at how many providers are there per 10,000 people. In this graph, you can see if we're in America, we always complain, right? We don't have enough doctors per people. America is actually doing fairly well. When you look at parts of Africa, you're looking at less than 0.3 physicians per 10,000 people. And that is the case for Tamale. Is actually, we looked at the data the other day, it was like 0.15 is currently. So having a pediatric endocrinologist there is a really big deal and really awesome that I'm going to get to have that experience. So when we look at endocrinologists around the world, so adult endocrinology, obviously there's going to be more of those than pediatric endocrinologists, but in sub-Saharan African countries, they are estimated that there's 0.03 per 100,000 people for an endocrinologist. In America and Europe, just to give you an idea to contrast, there's 0.89 or 4.84. So definitely a big difference there between those numbers. It's estimated that there's a total of 60 pediatric endocrinologists in the entire continent of Africa, and I can name 10 that just work in our department. So that's a pretty crazy number when you think about it. There are roughly 7,000 pediatric endocrinologists that are currently registered. I don't know. Registered in the European Union, and as of 2023, there were 1,494 pediatric endocrinologists in the US. So what are the most common endocrinopathies that we're thinking of? I feel like when I was in medical school, the answer to this question was always a goiter. Goiter was the most common thing worldwide. But when you look at the newer data and the newer literature, the World Health Organization is actually saying that type 2 diabetes is actually maybe surpassing goiters in the world. which is a little bit crazy when you think about it. And then when you add type 1 diabetes with type 2 diabetes, that makes it surpass it. So thyroid disorders are still very common. Hypothyroidism is one of the most common things that we see. And then growth hormone deficiency is another one. Adrenal disorders slower down the list. Precocious puberty and hypopituitarism. Endocrine disorders account for roughly 8% of the global disease burden. And what we're seeing globally is that we're seeing an increase of chronic disease, which is very important as we go along and think about these things. So I'm going to start talking about type 2 diabetes. When I started researching for this project, I was pretty shocked based on the numbers and the data that I was seeing for obesity specifically. But obesity is increasing worldwide, the same as it is here in the US. It's currently 16% of the global population, and it's doubled between 1998 and 2022. The shocking thing is that depending on which resource you read, the World Health Organization estimates by 2035, some other organizations say 2040, that over half of the world's population is going to be considered obese, which is a BMI greater than 30. Everything always documents about Mexico and their childhood obesity rates. Nearly 30% are already obese or at risk, and it's due to their poor nutrition or lack of exercise. And more than half of those who qualify for type 2 diabetes do not have access or coverage to the medications to treat their disease. So why is this happening? What's going on that's changing kind of the whole world? It's not just happening here in Kentucky, but also just everywhere. The increase in processed foods is happening. You know, the more that we always say the world's becoming a smaller place because we can share more of our ideals, we can share more of our things, but we're also sharing more of our processed foods as we do that, and we're able to trade things. Countries that previously relied on most of their agricultural and things that they grew themselves are now finding that maybe it's cheaper to just have things sent over that are probably less nutritional value, but cheaper in price. Also, increase in sugar intake. I just think that's a worldwide thing. That is what it is. Urbanization is another one. So as we are making great progresses and we're building infrastructures and we're doing all these things, there's an organization called Engineers Without Borders. They do awesome work. But as we do that, we have to also understand that we're taking a toll on our green spaces and taking a toll on the areas where maybe physical activity or other things could be done to promote healthy living. And then climate change is always brought up as we go through this, and I have a fun photo later on about climate change. And then safety. Is the world more safe or less safe than it was years ago? As more and more wars go off and we have more and more displaced people, the question then becomes, is the focus more on healthy living, or is the focus just on living and surviving? That's important distinction as we think about global health. This is a map to show the incidence of, or the prevalence of type 2 diabetes. It is a problem worldwide, as you can see, but the thing that is important to point out from this map is how much is it increasing in what parts of the world, right? So type 2 diabetes is very much a problem in most developed countries at this point, but the biggest increase that we're going to be seeing in the next few years are going to be coming from those places that don't have doctors, that don't have access to certain resources, where medications are hard to get to and they're more expensive. And it's definitely important for us as endocrinologists to remind ourselves of these things as we go along and as we come up with future ideas. Whenever we talk about global health and global health crises, obesity is listed. The World Health Organization has listed that, but they've also listed metabolic diseases that go with it. So with type 2 diabetes, you're going to get your hypertension, you're going to get your metabolic syndrome, your hypercholesterolemia, all of these things. And then along with an increase, there's autoimmune disorders that are also increasing. So it's a huge issue. So what are we doing? What have we done so far as endocrinologists here and around the world to make these things known and to try to make an impact? World Diabetes Day was one of the big things that WHO like advertises and says that this is a big part of why they're addressing these issues. It's November 14th every year, and it's a day when they use their platform to add education, make up public health campaigns, spread it around the world. If you go to the WHO website, you can actually see every single country and what they're doing and what organizations they're working with on World Diabetes Day to see it, which is awesome. The Global Diabetes Compact. So this is a mission that the WHO has developed. It's a starting ground for ways that we can actually reduce the risk of diabetes and make access better for affordable care for the whole world. It's an actual document that they have on the website, and it's a way to also use this. How can we integrate this into policies around the world too, from a legislature standpoint? Prevention programs are hugely important. We know type 2 diabetes, the best thing you can do is prevent. So that is something that we can come up with. And then making sure that making sure that there's not policies that are going in place that are making it harder for our patients to access care or harder for our patients to afford their care. And then advocating. Making sure that we are advocating as physicians, but also advocating as telling our patients that they can advocate for themselves, their families, that they can advocate for themselves. Just try to make it. So I want to take a pause and just think globally, here are the way things are, but how are we doing in Kentucky compared to all of this? So in Kentucky, 3 out of 10 adults are considered obese, which is a BMI greater than 30. Only 1 out of 10 adults currently meets the physical activity recommendations. We are ranked second, actually, for childhood obesity. I think it's gone back and forth, but in 2023, we were ranked second. It's very close. We're 24.6%. And West Virginia is 24.8%. Mexico has the highest, and they're 30%. So we're pretty close. Kentucky ranks 7th in the U.S. for percent of adults with type 2 diabetes. And then we look at children with type 2 diabetes. Obviously, that number is going to be lower. But it's concerning that it's any number. But it's 0.29 per 1,000 for the ages 10 to 14 years old and 1.04 per 1,000 for the ages of 15 to 19. This data was obtained in 2023. I wonder if this data has increased since then, and my guess is that it has, just based on what we're seeing in our office and the things that we are seeing in the hospital. And I think it's important for us to take a moment and just think about what are we doing as an organization to even address the things at home in Kentucky, as we are a more rural area. And a lot of these issues that we talk about, like Asia and Africa and countries that maybe don't have as much, a lot of our rural areas also don't. So this is kind of where it plays into my hometown and where I'm from, right? This is the importance of getting that access to care and seeing that happen. But we are doing some things, and in 2001, we did make a foundation that I don't know if everyone's aware of. I actually learned about it when I was doing my research, but it's Foundation for a Healthy Kentucky is actually something our legislature provided an endowment for, where they will support community projects to kind of promote health and prevention of obesity and type 2 diabetes. They will also help to fund research that promotes healthy living in any way, and they do support policy that improves children's health and addresses social determinants of health, especially in the rural areas of Kentucky and eastern Kentucky. And then looking at treatments of diabetes, it would not be a global endocrinology topic without discussing the prices of GLP-1s in this country and around the world. But I looked into kind of metformin as our cheapest option, our first line way to treat type 2 diabetes. Because of worldwide campaigns that the International Federation of Diabetes has done, the World Health Organization, metformin is pretty much widely available around the world now. In South Africa, we did have it. I did work with an endocrinologist the 2 days that he was there for that time. And that was the only medicine that we could provide. In low-income countries, though, 26.9% of patients still cannot afford metformin, even though it is available. I looked at the cost of metformin. It was a little bit hard to find, but in China, a 500 milligram tablet costs roughly 6 cents, but in the US, I mean, I know that these are cents, not dollars, but it is significant when you compare our drug prices to them, even on a medicine that we've now made worldwide available and comparing those prices, but it is 17 to 50 cents depending on what you're reading. And then looking at GLP-1s, right, we know that these are now becoming probably the best medicines that we can use because you get the cardiovascular benefit as well. And when we compare the US, we are paying roughly $1,000 for GLP-1s when other countries are paying a lot less. A lot of that goes into our policy and how our legislator, how our government has decided to interact with drug companies versus how other countries have decided to interact. But these medicines aren't available in lots of the country because of the prices that they are. Because even though those prices are smaller in Australia or the UK, they're still way too expensive for a lot of countries to have. And then going on to type 1 diabetes, that is going to be more of my focus, but it's more common in Europe and North America, but it has a rising trend in children, as we saw from Dr. Montgomery's presentation last year. You know, we're having more and more diagnoses. In 2021, there are 8.4 million people in the world living with type 1. This is estimated to essentially double by the year of 2040 because of how much the rate of increase has happened. The World Health Organization European region has the highest burden of type 1 diabetes, as we know, with an estimated of 295,000 children and adolescents living with type 1. And then we know that Northern European nations are more likely to have type 1, especially Finland. I've been told that's 4 question in the past. And then it's estimated that 1 in 10 people living in the WHO European region will have diabetes by 2045. So this is something that is going to continue to be a part of our lives, continue to be an issue. But then we think about what is the only way that we can treat type 1 diabetes right now. And the only way is insulin. So our biggest barrier from a global health standpoint is that how do you get the insulin to them? If you get it to them, how do you store it? If you can store it, how do you give it to them? How do you actually administer the medicine? So it's estimated that half the world's population who need insulin don't have access to it. So as many as 25 to 30% of the people with diabetes, even in the US, report that they have rationed or skipped their insulin due to cost. And I know that I'm speaking to the choir here, but you all have talked to patients that's the case, right? Like we ran out of insulin, or we took our dose down because we were trying to make it last a little bit longer. And then the things that we need for insulin, we need syringes, pin needles. You have to have refrigeration. A lot of people around the world don't have refrigeration. Long-acting and short-acting insulin, right? So it's not just one insulin that you can give yourself. And then also thinking about if we are becoming a more obese world population, you know, insulin is not something that you just take a pill for the day and that's what you get, and that cost is always going to be the same. As we're becoming larger, we typically have higher insulin needs for our body, so then you would need even more insulin. And then to keep yourself safe, you're going to need glucagon in case you take too much insulin. And then also, how do I make sure that my blood sugar is safe? Do I have a meter? Do I have lancets? Do I have strips? Are these things that are accessed? I know that in South Africa, when we met with the patients, typically what we did was they always got a package of metformin that we handed them, and then we also gave them generally strips and lancets at that visit that were paid out of a different fund. For that. But whether for someone with type 1, if it was enough to last them a month, I would say probably not. But right now we can't replace the pancreas, but hopefully in the future it will last a long time and we can come up with a better solution. And then looking at insulin prices, the same as GLP-1. This was a article from Yale School of Medicine that they had this picture in it, but you know, even here in the US, insulin is costing $99 but compare that to the same volume of insulin around the world is very stark. And then we go into technology. As we have changed our technology, made our type 1 diabetes technology even better, we've gotten better A1Cs, better treatment. As we know, we use CGMs, we use Dexcom G6, G7, Libre 2 and 3. Something that we don't have yet in this country is going to be an Accu-Chek Smart Guide sensor, which is actually the picture on the bottom here. So the blue and white thing is just the thing that's like the insertion, just like the Dexcom. The white, it looks just like all the others, like the Libre 3 and the Dexcom G7. And it works the same way, it goes on your phone. So this sensor has now been available in most countries in Europe, I believe, and I think the Middle East based on what their website, how their website reads. So what's different about this one is that it uses AI technology to predict what blood sugars are going to do. So the extra features that it provides is that it tells you what your blood sugar is going to be in 2 to 4 hours, but then also provides a prediction based on a week's worth of data of when, if you're going to go low that night, to help with dosing instructions for when you do dinner time or evening doses. So that's kind of the different thing that's going on there. And then Medtron is a CGM that also is used in China. It matches with their pump, the TouchCare Nano pump. So insulin pumps, Omnipod, Tandem, they're available all over the world. The Betabonic iLet is available less places, but still available. And then that TouchCare Nano pump is going to be the one in the top there. I'm pointing at it, but you can't see me pointing. And this is going to be a wearable patch pump that actually comes in 2 sizes. So that's the thing that's nice with it. So it looks like an Omnipod, but it can come in 200 or 300. So that's a different thing. As far as I know, this is only available in China. And I don't have a lot of Chinese data because they don't share everything. But that is an interesting thing that we could work towards in this country as well. And then the Vicentra Kaleido pump is a pump that's a Dutch pump. It's been around for a while. I like it, and the kids would like it because it's pretty. It's the colorful one in the middle. You can change different colors for your pump. You can also change different sites. It's pretty much like the Mobi. It's exactly the same. You can wear it, but also it has the site that you can take it off. So it's kind of the both. But those are kind of different technologies that you're going to see in certain parts of the world that you're not going to see here. But they did do a study called the SWEET Initiative from 2015 to 2019 that was working towards how do we standardize our diabetes, our type 1 diabetes treatment, and reduce inequalities. And what does the data look like for the world at that point in time? They did 96 diabetes centers around the world. All of the participants were less than 21 years old. I think the interesting part in all of this was that the pump unit usage was the highest in North America, as we would probably expect. It was 80.7%. It was the lowest in South America at 4.2%, but the A1C actually did not correlate with the highest or the least amount of pump usage, even though they're all closed loop systems. The A1C was still the highest in the Asia, Middle East, Africa group at 11, and 11.3 of them actually had pumps. So double the amount of people had pumps than in South America, but their A1Cs were still higher. I don't know why this was, but I think that it's something to think about as far as access to care, cultural beliefs, what was impacting that. I don't know, but it's an interesting conundrum. But then thinking about what are the other things that go along with type 1, DK is obviously how most patients are going to present, even still in the US, but it occurs even more frequently in areas where there's limited access to care because they're probably going to wait longer until they finally do seek that care. The other thing is that what do you do if you don't have the ability to give IV insulin? What do you do if you don't have the ability to give IV fluids? How do you handle DK in that scenario? There are guidelines that are available in multiple research journals. This one I took from an organization out of Australia that I like because it's just prettier. But you can give subcutaneous insulin and treat DKA from that way. This even goes to far as if you're really resource limited, you can even give oral rehydration instead of giving IV. If you don't have IV, then you have to give it oral. Obviously, you would use the if anyone's ever seen these packets, and it's from the World Health Organization, but they're the oral rehydration if the kiddos have diarrhea illnesses, because that's the number one killer of children in the world. But so that's something that you can do, or you can make it at home. Usually what it has a little bit of dextrose in it. You have potassium, you have salt, it has all of those things. So it has those electrolytes in it. But even if you are giving the oral rehydration, you've given subcutaneous insulin, there's not a scenario or not an algorithm where you don't need to check a blood sugar. You don't have to have a glucometer around. There's not a scenario where you don't need to check the potassium, the thing that could kill the child. So I think that's important when we think about diabetes or DKA, when we approach it kind of around the world. And it's important to think about. And it's actually very interesting because before they would let me be chosen or selected to go to Ghana this spring, the doctor actually sat me down and said, children are going to die because they're going to come in DKA and we're going to have no insulin in the fridge. And you have to be okay with that. And that's hard. That's tough. That's tough, especially as endocrinologists. But I know that you're going to see that, and that's and you can't help it because you don't have what you need there. Thinking back in my experiences in South Africa, this would not have happened at the tertiary hospital, but in the secondary hospital, in our ER, children or adult, you were typically 3 to 4 people per cot of what was available. And if there was no cot, they were in the window sills, they were on the floor, and you got to them when you could get to them. There was no system of there was a system, but it wasn't like every patient has their own room, their own space, and you go through that way. It was more so. So I think in my head, like, could there have been a child that was in DK there that we just didn't get to that day, and we didn't see them that day because we were dealing with other things, because burns were a bigger problem for us. So people came in with burns a lot more. But yeah, it's important to think about. And then kind of moving on from diabetes, thinking about thyroid disorders. So typically why we talk about goiters is because iodine deficiency is the most common cause of thyroid disorders worldwide. It is the biggest issue in Asia. It's 11% of the population. Congenital hypothyroidism just around the world happens in 1 in every 2,000 births. But I will say that thyroid disease is one of the things where we've made strides and we've done a great job. So it is still one of the leading causes of intellectual delay and growth delay in children worldwide, but levothyroxine is cheap and has been listed as one of the essential medications for all countries and for all NGOs or any other organization that's going to go into a country and try to help out. Levothyroxine is cheap and we can get it there. It's a pill. It doesn't need anything specific. Another area where we have worked really hard as a world is newborn screenings. Newborn screening programs are now very widely used. Even in Africa, we had one in South Africa. But even that still, approximately 70% of newborns worldwide don't have access to newborn screening for congenital hypothyroidism. If there are countries that do newborn screening, generally the congenital hypothyroidism is the one that they do because they can do something about it. And then another area where the world organizations have really made a dent is making iodized salt available around the world. And it's now 89% of the world. So I am hopeful that these numbers will continue to decline. Of newborn screening will become more available as we keep trying to address that issue. And then thyroid cancer is also a big thing that happens and is a important issue globally because incidence of all cancers are increasing worldwide, but thyroid cancer specifically is increasing more dramatically than other cancers. It's the 10th most common cancer at this point. Half of the cases in the world occur in the Western Pacific part of the world, but mortality is still the highest in Africa. It's typically papillary or follicular carcinoma. And the biggest thing is it's not necessarily that they don't notice that they have symptoms. The biggest thing is, how do I get to an ultrasound? How do I get to a place that can do a fine needle aspiration to determine what kind of cancer? And then once I know I have cancer, then how do I get to a place where I can treat that cancer? And every country has a tertiary center where they can do this. It's just, is that feasible for the patient? And then going into adrenal disorders, and the biggest thing to think about when you're thinking from a global perspective is what's causing the adrenal dysfunction. So they're going to have higher rates of tuberculosis. It's a big portion of why there is adrenal dysfunction in adults, especially in Africa, as well as HIV can cause you. The infection can cause you to have adrenal dysfunction, but also you're more susceptible to have fungal infections, so adrenal mycosis. I actually did see this and had a patient die when I was in South Africa because of this, because he had TB and had a fungal infection that essentially took over his entire body, but it wasn't his adrenal gland. And then I just thought this one was cool. A viscerotrophic snake bites can cause your adrenal glands to shut down, and apparently that's something that happens enough for them to write about it in the tropics. And then thinking about our kiddos, it's going to be CAH, which is more common in the Mediterranean or India. Typically, when we think about CAH in America, it happens, but also it's going to happen more frequently in groups that are more, they stay within themselves. So Ashkenazi Jews, 1 in 3 carry the allele, 1 in 27 have the disease. In Morocco, they are more likely to have 11 beta hydroxylase deficiency. And then Eskimos, I thought that was interesting that they have 1 in 282. Almost every country that does a newborn screening, just like for congenital hypothyroidism, they also do congenital adrenal hyperplasia, which is awesome. There have been partnerships with lots of national ministries of health as well as international groups that have come in and raised awareness to help to understand congenital adrenal hyperplasia. A lot of this has to do with cultural concerns and how different cultures look at CAH because of the presentation that it often has clitoromegaly and those kinds of things. And there are a lot of very good organizations out there that are working on raising awareness that CAH exists. And there is non-classic and classical, and also that that it needs to be treated for what it is. Hydrocortisone and Florinef, steroids are still very cheap around the world, so there is access to get. Hydrocortisone is more available than Florinef, but you can get fludrocortisone pretty easily as well. But again, cost becomes an issue. And if you are ever in a scenario, even here in the US, I think if you've never been on the Global Peds Endo site, it's a free website you can join for free. But they have great resources for CAH specifically. So we do a lot of children's books and those things to understand my body and what CAH is. They have them in lots of languages. I'm not sure how many languages, but they have these books kind of explaining what CAH is, which is very helpful in a disease that you need to know a lot. Your proficiency needs to be pretty well to handle those situations. Now, is Solu-Cortef going to be available all around the world? I have trouble getting it in Kentucky a lot of the time, so that is not an option, but hydrocortisone is available. And then thinking about precocious puberty, this is, I'll just review this, but this is puberty before age 8 in girls and before age 9 in boys. As we're looking at obesity trends, for childhood and adults. We're noticing that puberty is happening earlier all around the world. In most countries, you're not going to be able to get an MRI. You can get some laboratory testing, but it's not as available. And a bone age you can sometimes get, but are you going to have someone who can reliably read it is going to be the next question. And then also just cultural beliefs and cultural approaches to puberty. I see that even in Kentucky and even here and even where I'm from. Different people approach puberty differently. Different people talk about puberty or don't talk about puberty based on their cultural beliefs or their religions, and that affects whether they seek out care. So a lot of the numbers that we have on precocious puberty from a worldwide standpoint are probably just estimates, and they're not actual direct reflection of what's happening in the world. But we know that if we have precocious puberty, we're going to have shortened adult height, and we have an increased risk of metabolic disorders. So there's been a big push, especially from Global Peds Endo and other global pediatric endocrinology societies, the European societies, have been pushing to raise awareness that precocious puberty is when you start to have breasts before you're 8, or you start to show signs in a boy before 9, and trying to raise awareness so parents know that this is a thing and this is a thing that we can do something about, but only if you're in a scenario where you can do something about, because that's not always good. And then thinking about growth, worldwide growth is going to be nutrition, 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 right? Kids aren't growing because we don't have the calories that we need. We see that here as well. Growth hormone stimulation tests, I don't know that it's performed at all in low-income countries. I never heard anyone even suggest such a thing in South Africa, where I was at least. And then some sources estimate that each half-inch in final height gained via growth hormone costs anywhere between $18,000 to $36,000. When you think about that number, for myself, sometimes it makes me think, like, what am I doing every single day in my job? Like, is this making a huge difference? Is this something that we should be doing? Is there better allocation of our resources, better things worldwide than we could be treating instead of growth? But it's something to think about. Obviously, because that medicine is so expensive and your benefit is probably a few inches, that's not going to be the main concern. If you're also worried about, am I going to get clean water this week? Am I going to get food this week? And if anyone has ever been to Paris, this is like the rich part of Paris where everyone is a celebrity or a millionaire to live there. So that's why it's appropriate for this slide. And then hypopituitarism, this is still very rare everywhere. It's estimated that there's 45.5 cases per 100,000 people. Most common causes are going to be brain tumors. You might see in lower income countries, and as war gets more diverse, that you're going to see more hypopituitarism from TBIs, traumas. Also, meningitis is still one of the leading causes of mortality around the world, which we know hypopituitarism can happen from there. And then Sheehan syndrome is another thing that happens more so in lower income countries than higher income countries. Also, for diagnosis, you're going to need lots of laboratory testing. It's going to be expensive. You're going to need imaging, which you're probably not going to have the right imaging to see what you need to see. So this becomes very expensive very fast. When we think about especially diabetes insipidus, DDAVP, when I was looking at DDAVP in the cheapest country I could find, it was $240 for a 30-day supply of DDAVP, and that's in US dollars, so that's unrealistic for a lot of parts of the country. When you read of how do you approach it in limited resource settings, they say focus on oral rehydration, hoping that they are able to do that and hoping that they have intact thirst. But typically these children will die from their diabetes insipidus. So thinking about cost. And then just as a broad statement, how many of these disorders are going undiagnosed just because we don't have the access to care that we need? How many of these things were giving us values, we're looking at these numbers, but how many of these things are happening and we just don't know it? And because they don't seek care, because they don't have the ability to get it. And then it wouldn't be right to not talk about the pandemic because it changed everyone's view of the healthcare system, regardless of what part of the world you were in. It also made our healthcare population decrease. We lost lots of doctors and lots of healthcare staff, but it provided more opportunity for global health data sharing. A lot more countries started participating, sharing their numbers, sharing information. It improved the reach and the use of telemedicine because it was telemedicine or don't exist for a little while. So that is a way that we can kind of think about how can we reach some of the people that we can't usually reach. Obviously, we need internet for those things, but different ways that we can approach telemedicine. And then public health. So when we think about public health strategies, we're thinking about primary prevention is usually what you're thinking of, vaccine programs, encouraging healthy lifestyle, environmental changes. But maybe more as subspecialists, how do we do secondary prevention? So finding measures to keep communities safe from external factors. How do we improve our access to our healthcare? How do we get our healthcare to our people? We can do this through surveillance. We can do this through interventions, education, policy, advocacy, community engagement, and then even just doing data analysis, evaluating, and then figuring out from there how we can use our other strategies to make a difference. I highlight this picture because this is a typical township that you would see. And I think sometimes when people think about global health and talk about these things, it often gets very depressing. But these townships are wonderful places. These are, doctors and lawyers are living here. This is not people who don't have jobs and don't go to work every day. It's just that community feeling that evolves, and there's a braai every Friday and everybody's grilling out and having a good time. It's just that community that you are a part of, and that's a great way that we can bring that care to them in their own townships and raise that awareness and make that education happen. And then this is my favorite when we think about, this has nothing to do with climate change, but it's like prime example of like there's signs everywhere saying these volcanic fumes are hazardous to your health and can be life-threatening. And then as I'm looking at that sign, I turn around and there's a child playing in the volcanic ash smoke. That volcano is now actually erupting, but yeah, that's my favorite pictures that I've ever taken, I think. But then also, how can we continue to work in our own neck of the woods as we are a rural community? Diabetes camps is an awesome way to do it. There are actually world organizations that families that have been affected by diabetes and have had children go to diabetes camp. Well, they will sponsor diabetes camps in certain countries in Africa, which is an awesome thing that happens. Also, just evidence-based medicine, making sure that we're practicing the way we should be practicing. Data sharing, using our information to help other rural organizations or using their information to help our organization. Technology improvements, that's ever changing. And then building relationships between different organizations in Kentucky, the US. How do we always make sure that healthcare is at the top of our priorities? Healthy living is at the top of our priorities and not necessarily trying to treat diseases. And then talking about what are some of the resources and organizations that we can go to look for more information, more ways to help, or ways that you can get involved. World Health Organization is going to be the most information that you're going to find. They're They have the most data around the world of what's going on from a public health standpoint. And it's very easy to access and very easy to understand. You just pull up a map, you click what you want, and you click where you want in the world. UNICEF is another organization that's made huge differences in the world. For diabetes specifically, we have the European Association for the Study of Diabetes, as well as the IDF, the International Diabetes Federation. Like I said, Global Pediatric Endocrinology and Diabetes, the International Society of Endocrinology. And then when you think about Médecins Sans Frontières, it's going to be your Doctors Without Borders. They do accept subspecialists if you want to take that route. Typically, they are a more let's get in, let's fix a bad situation, and then let's get out. So if that is your personality and your type, then that is the job for you. But as a subspecialist, they will usually only take a few at a time. They typically go for ER doctors and generalists. And then a really cool organization that I found while I was doing all my research was called Life for a Child. It's an organization that actually Diabetes Australia supports, and then it was a family who was affected by type 1 diabetes. And they actually are working on getting insulin to countries all over the world. And they have a map, and it's kind of amazing how much they have been able to do, because New Zealand has a lot of issues with insulin availability. So I think it had started like, let's get this to New Zealand, and then it's progressed from there, and now it's in the Asian Pacific, it's all over Africa, and they're an awesome organization, and they also do some diabetes camps as well. But yeah. And the picture is kind of silly, but I have an English brother, so when we have weddings, there's always a ping pong table, and it's always England versus America, and it's exciting. All right. Well, any questions that anyone has or anything? Yeah.
Thank you for all the work you've done internationally. So now at this point, not being part of
yes, I did not include USAID on.
Gone, so how much of the continue the impact we've had for these countries and these children?
Yeah.
What do you see going forward?
I think that I knew this question was going to get brought up, and yeah.
Everyone in the room and virtually, because I know it's in everyone's mind.
Yeah. So those online, the question was with the political climate the way it is, and the loss of the funding for USAID, kind of what do we foresee how things are going to go, or are we going to lose some of the things? I think that to be entirely, I want to put a positive spin on this, because I feel like we always talk so negative about this. From my perspective, America, as far as endocrine specific things and diabetes specific things, we really aren't the ones driving the charge. So I think from that perspective, I think that all will hopefully still be okay. From a infectious disease, HIV, so to give you an idea, the AMPAC program that we partner with, AMPAC Ghana is perfectly fine from a funding standpoint. We are not funded by USAID. We are not funded by PEPFAR, is the HIV organization. So they have a Kenya branch that does HIV medicines, and they are completely shut down. The people who work there have decided to stay there, and they will continue to work despite not being able to be paid. And they're giving out the medicines that they have left. So everyone's scrambling for money. Money makes the world go round. You need money to do these things. So I think that everyone's trying to get creative right now to try to keep their organization afloat. I know that the organization I worked for, well, not the main organization, but one of the separate organizations I worked for in South Africa was a big tuberculosis and HIV clinic, and those have all shut down because they were funded by USAID and they were funded by PEPFAR. There's some talk that like they might open one or two of the clinics, but they did have clinics in different locations around Cape Town. So it's hard. It's hard to know, but also remembering that, we can still fight the good fight with what we can do within what we can do, and we can partner up with our European friends and our friends from around the world and still try to make a difference. I think that's going to be the goal, at least for the foreseeable future.
I know the idea.
Mm-hmm.
In India, like South India, one of them, the center.
Oh, awesome.
So I know we partnered in the past.
Yeah.
I also just wanted to comment, like the GLP-1, because I mean, this is all global, but
Always.
what's happening here.
Yep.
So Australia, $87, that was very impressive. But I know Novo just came up with a plan where you can go into, they have a website,
Mm-hmm.
and even if your insurance don't pay or cash pay, $500 per month.
Okay.
You're able to get supplies.
That's good.
Just happened today.
Okay.
Yeah, so they should be coming with that.
I would rather it be 90, but
No.
I'll take 500.
Australia sounds good like that.
So there was a congressional hearing about the cost of the GLP-1 agonist, right? And so you had like Bernie Sanders saying, why is it $100 in these other countries when NIH funded the majority of the research that developed this drug? The folks from semaglutide was on the list that was supposed to be negotiated for Medicare, and that program was shut down. But one of the Novo reps was at the Kentucky Congressional Society meeting recently. You were there, Dr. Michigan. So I was talking.
Yeah, actually.
Oh, you were.
He stepped out.
Shigunda was there, but I
Yeah,
was talking to this rep afterwards and said, when is the price going to come down? And he said, we're prepared to negotiate. Yes, but the government's not going to ask you to negotiate anymore. He said, well, I think that they'll still ask us. I think they'll still ask us and we'll negotiate, and the price over the next 5 years will definitely come down. But that is 5 years is a long time.
Yeah.
When you have patients saying, this could help my kid, what do you mean?
Yeah, but at least, I mean, I is a lot for most people, but it's better than, so they have that link. I just shared with all my colleagues. It was in the news today, so.
Yes.
And I think few the guy who's doing it for Kentucky, and they shut down the house.
Right. And some of the Zepbound from Lilly,
They have
bonus dose is $350 a month. It's a similar plan, but you can get it for a little bit less, for at least the initially or
the lower dose. But
Yeah.
this one is Wegovy and something.
yeah.
So
And Qsymia is closer to $100 a month.
okay.
So that for $100 a month.
Cheaper.
Yeah, I know it's not relevant to global health, but
You can't not
I
talk
think
about
good
it.
enough. But
Yeah. Well, I think that's the point, right?
We will make sure that
We maybe aren't good at certain things too,
Yeah.
is the moral of the story, right? Everyone has things they're good at and they're not. Someone asked in the chat, are you able to coordinate with WHO for global public health information in the current political environment? I don't know the exact answer to that question. Unfortunately,
I think we are still part
Yeah,
of the future.
yeah, I think that you can, as far as I know, but I don't know the specifics on that. I mean, I think the World Health Organization, if you just sent them information, they're gonna use it. So
We still are part till next year.
Yeah.
So maybe things.
Yeah, we have to give them a year notice. So January 22nd, 2026 is when our membership expires.
all right, Dr. Watson just Googled it and it's January 22nd, 2026. We're good for right now.
But I think the World Health Organization is going to turn their backs on us. We're
Yeah.
the ones that are turning their backs on us.
Yeah, I think
Yeah.
that
the other way around.
if we submitted anything or reached out to them, they would respond as physicians.
Yeah.
Regardless of where we live.
Thank you so much.
Yeah, thank you.